Welcome to the next installment of Live Well with UCI Health. My name is Gina Grad from Alt 98.7 and iHeart Radio, but that's not important. The really, really important people who I'd love to introduce you to are Dr. Jaehyun Kim, aka Dr. J. Kim, that's what all the cool kids call him, gastroenterologist specializing in common digestive conditions and colorectal cancer screening, and Dr. Catherine Zhu, colorectal surgeon specializing in minimally invasive surgery, including laparoscopic and robotic assisted surgery. What amazing. In the treatment of colorectal diseases, both from UCI Health. Thank you both for being here. This is really, really exciting.
Thank you for having us here.
Absolutely. I'm going to first jump in. I always like to kind of horn my way up to the front with personal questions because, I feel like it's one of the perks of being here. I just had my first colonoscopy, and I'm one of the people that was a couple years late to the party because I didn't want to do it. And I kept putting it off and I kept going, no, I get it. It's important. And then going, I have to wash my hair that day. So, it was, let's see how I'm doing in 6 months. And I finally just was smart enough. In fact, somebody who I know had just been diagnosed and they said, this is not a joke. Mm-hmm. This is not something that's like, maybe I'll get my hair cut a different day. This can be life or death. Would you like your life to be saved? I said, I most certainly would. I did it. It is so not a big deal. I'm asleep.
Yes.
What do I care? So I just want to first say on record, as someone who's a big giant baby who cries over a hangnail, this is not scary. Mm-hmm. It is not a big deal. And I'm so happy to have a clean bill of health. And I was told, I think I don't have to come back for like 7 years, mm-hmm. which to me feels like the grand prize. Yep. So I want to make sure that other people understand that not only is this unbelievably important, but it's just not that big of a deal. Does that ring true for you both as doctors?
Yeah, I think it's one of the most commonly done procedures in our field, in the medical field. It's recommended that now everyone over, at age 45 or above, or earlier if you have any, family history of colon cancer, polyps get done earlier. I always tell my patients, really the hardest part of the colonoscopy is really not even the procedure. When you come for the procedure, we'll give you medications, mm-hmm. sedate you. Some people can actually even do it without sedation if you're interested in that.
That's not something I'm interested in.
I know. Most people are not, but some people are. The hardest part, for most patients is the prep.
There we go. That's right.
Yes, which is a very nice way of saying, I'm going to make you drink a lot of laxatives, and you will need to be by your bathroom the whole night. You
know what, though? Again, I was really scared. Not that big of a deal.
Bad.
And I remember when my dad did it back in the day and he had to drink like a giant jug of literal salt water.
Yes.
This is it was like Kool-Aid. It's not a big deal.
No, we've come a long way as far as bowel preps go. So there's kind of lower volume prep where you drink like a 8 ounce of laxative followed by, 3 bottles of water.
That's
or
what I did.
Crystal Light,
mm-hmm.
Or Gatorade.
Right.
And even if you do have to drink the big jug,
mm-hmm.
I always tell patients, put a Crystal Light mix in it. Trust me, it'll taste a lot better because it's, without it, it does taste like drinking, seawater.
So you're allowed to mix stuff like Crystal Light?
Yes. And typically, we might even say drink, you can mix in clear, so whatever's clear liquid. So like Crystal Light lemonade, even Gatorade, as long as it's not like red, purple color.
I also got that warning as well.
Water's always, a safe choice.
Yeah.
But any of those are good
Well,
options.
and that's, I was told basically by the doctor, not in these words, but stay away from the blue and purple, popsicles because we don't want you to, the good news is you're healthy. The bad news is, did you know you're part Smurf? You're not going to be able to see most of the things you need to see if I'm purple, right? Or blue.
It's interesting. So every instruction has that. And, which I think it's fair. I think it can interfere with sort of the seeing certain parts of your colon.
Okay.
But, and so we do ask avoid anything like kind of red color.
Yeah, cherry stuff. Yeah.
But, and so, tell patients to get like lemon lime flavor or blue, or like those like, kind of anything that's kind of clear. That's again, just avoid kind of red or purple kind of color.
Okay, so really, this is a person you are trusting with a lot, being unconscious and them having to do what they have. Don't make it harder for them.
Right.
That's what I would say.
Yeah.
So what exactly is colorectal cancer? Can we just kind of start at the beginning? Because this might also be a stupid question because, I assume like colorectal, rectum, colon, but where does it start and how do we get to that diagnosis?
Yeah, I mean, I think everyone's familiar with the word cancer and what it is, but basically, if I had to define colorectal cancer, it's a massive malignant, cells that continue to divide until it invades into your colon, and it most often starts in the lining of your inner lining of the colon and your and the rectum. So colon is the last part of your digestive tract.
Right.
So it starts in your mouth, into the esophagus, stomach, small intestine, and the colon and the rectum, which we do differentiate it, but really they're all kind of the same part. I guess
the same highway.
Exactly. It's about 5 feet long, and it kind of starts in the right lower part of your abdomen.
Okay.
Comes all the way around to like just below your rib cage and to the liver, goes across to the left upper part of your spleen, and then kind of goes down and where it connects with the anus.
Okay.
Yeah.
And then it's just all jumbled in there. It's really none of our business. That's your business.
Kind of makes like a big question mark.
Yeah,
actually.
okay, got it.
The small intestine, I would say, is jumbled up in there and sort of free floating, but the colon itself is anchored in this box or this question mark shape.
I'm glad you said that, and that's a great time to remind you that there is nothing you can say that is too simplistic for me. So please, saying it's anchored where it's supposed to be works for me.
And like Dr. Kim said, the majority of them start on the inside lining of the colon. And so that's why colonoscopy is recommended, because we can physically see those polyps forming and developing into a cancer. Whereas a lot of patients ask us saying like, well, I had a CT scan a few months ago. They didn't see that. And the answer is no. A lot of times they're too small to really be picked up on MRIs or CT scans until they grow to a certain size in which you wish you had gotten it treated before it got to that size.
Yes.
So that's at the point at which they start to become visible on imaging.
You're already pretty far down the road.
Yeah, or developing symptoms. It may have already grown to a pretty big size.
So you mentioned symptoms. What are the symptoms?
I would say the most common symptoms are, rectal bleeding or blood in the stool.
Okay.
Change in bowel habits. So all of a sudden, let's say you were regular as a clock for most of your life, and all of a sudden now you're feeling more constipated. You're having trouble going, or now all of a sudden you're having diarrhea. That's new for you. And I'm not talking about diarrhea after you ate out and had some spicy
I was
food.
in a hot dog eating contest.
Exactly.
Yeah.
I'm talking like now there's some change you've noticed that's consistent.
Right.
That's not temporary.
Got it.
And of course, abdominal pain can be one. Weight loss, and then all of a sudden, also like your stool changing, like in consistency. Like again, like you've had certain consistency all your life. Your diet hasn't changed, and then boom, all of a sudden now it's very like thin, or so something's different.
Okay, I'm actually glad you brought that up, and challenge accepted to embarrass me. So. We were talking about this on the radio show that I co-host, and because we really were trying our best as, just normal dummies to try and figure out like what's normal when it comes to bathroom habits. And we were made to understand that when it's very thin, long and thin, that can be a problem. Why is that?
Again, everyone has like a range of normals, right? I have a lot of patients come to me and says, like I'm not having one bowel movement every day. It's like every other day.
Right.
And I've been like this all my life, and I reassure them
that's your body.
Exactly. Because there's a lot of role play. The reason why we get concerned about all of a sudden kind of like this gradual but persistent change in this long, thin stool is if you were to have a mass, especially like in the rectum or the left part of your colon. So when a mass or cancer grows, it tends to kind of grow inwards as well as outwards. So the opening diameter of your colon is more narrow.
Okay.
Now, of course, I would say the most, you can still get narrow stool from your diet as well.
Right.
Like if, last night.
Don't everybody run to WebMD, please.
So like if last night you had, normally you're very like a lot of vegetables, fruits, a lot of fiber, and then yesterday was your wedding anniversary, your cheat day. You go out to a nice steak restaurant. You're not going to get a salad. You're going to get a nice porterhouse. So then maybe the next day
loaded baked
it's a little
potato.
not a lot of fiber, and the next day might be a little narrow. But again, it's more of that. So but then if you go back to your regular diet, it goes
should
back
go
to
back,
normal.
or it should reflect what you're used to.
Exactly. But,
Okay.
but consistent thinning of the stool when you haven't changed your diet.
Okay.
And, especially if present with other symptoms.
Let me ask you this. I know this has become kind of a buzz phrase, and to be honest, I don't totally understand it. I've been told I have it by a doctor, and I go, okay. But what is leaky gut? Is that a thing?
It is something that we talk to patients about. I think probably Dr. Kim talks a little bit more to patients about it.
Yeah.
But the idea that the cells of the intestine have attachments to each other, so they form a layer. And when there is inflammation involved in the gut, it causes a change in signals and cells touching each other and the sort of molecules that they produce. And the connection between the cells is not so tight anymore.
Oh, so it becomes more like a mesh, like
exactly.
With
Yes,
openings.
that's a great way of putting it.
Okay.
And basically, it's like another way to say that there's inflammation in the gut. And and so that is sort of not really
like a science term.
It's not really associated with cancer itself.
Okay.
It's something that can indicate that perhaps your gut health is not.
But like you said,
best.
it indicates inflammation.
Correct. Yeah.
Also, something that is very, very scary to me is people are getting diagnosed younger and younger. This is something when you think of like colorectal cancer, you're like, oh, my grandfather, he was 78 and, this just hit him. This young people in their 30s, this is happening too. Do we have any explanation for this?
There's a lot of theories,
Okay.
but we don't exactly know.
The short answer is we don't actually know.
We don't know.
Yeah, there's not a slam dunk. There's not a smoking gun.
Got it.
There's a lot of potentially contributing factors. But yes, we are seeing it in younger and younger people, and we're seeing it in the media all the time of people that we know, people that are famous who are suddenly struck with this disease.
Yes.
And again, that sort of goes back to what we were talking about earlier, is that the symptoms may not be apparent until the cancer is quite advanced.
Right, which is why you want to get this checked out far before. And
to be clear, while it's very frightening that there are so many young people being diagnosed, we do have to remember that the majority of people getting diagnosed are older people. So colon cancer is still a cancer of older people. And if we look at people who are in their 70s, 80s, the risk of colon cancer is like, 200 to 400 per 100,000. Wow. So these are all big numbers, but it's very high. Whereas for people under 50 years old, which is what we call early onset colorectal cancer, the number is more like 10 to 12 per 100,000.
Okay.
So as Dr. Zhu mentioned, you look at the most recent data for how many people are getting early onset colon cancer. You're talking about at 13 patients out of 100,000 each year who are under age of 50 will get colon cancer. So that number compared to 200 to 400 out of 100,000, it's still much lower.
You need to put it in perspective. Yeah.
But here's a perspective that is scary and alarming for all of us in this field is the incident rate. The rate has basically quadrupled compared to 50 years ago. So back, in say 1950, only maybe 2 out of just giving you a number, there are only maybe 2 or 3 out of 100,000 had it, but now 13. So now 13 is now.
That's a jump.
It is a jump. And again, we don't exactly know. There isn't a smoking gun. We do think a diet plays a role. We do think processed food plays a role, all of these things, but ultimately we don't have an exact reason why. And so a person born in 1950, if you're born in 1990, like I was, I'm a person born in 1990 is twice as more likely to have colon cancer compared to someone at the younger age than someone born in 1950, and 4 times more likely to have rectal cancer. So it's all about perspective, right? So overall, the number is still not. It's only 13 new cases out of 100,000 compared to 2. And again, there's hundreds of millions of people between age 20 to 50.
Yeah.
And we are Dr. Zhu and I, we work together, and we have a handful of patients who are in their 30s and some rarely 20s.
the thing that is sort of more alarming for us as doctors is the trend, and the trend of these younger individuals being more and more likely with each year to be at a higher risk of colorectal cancer. And actually, a report came out just a month or two ago where, they found that actually colorectal cancer is the most common cause of cancer death in people under 50. Of the top 5 causes, colorectal cancer was the only one that has been having an increasing trend, whereas the other 4 have been having a decreasing trend.
I'm wondering if some of that has to do with, like we've talked about when we want to hit people over the head with it, the kind of like shyness factor. I don't really want to do a colonoscopy, and I'll just if I wish it away, I just don't want to think about it. So I'm just hoping that people are really aware. And also, I know that it's, like you said, it's standard to start when you're 45. Do you think that age will come down given the stats?
It's so hard because of what we talked about is the absolute number is still so low.
Right.
We're talking a full 10 times less risky than people in their 60s, for example.
Okay.
So it's still, the absolute number is still small. And if you increase the number of screenings, particularly with colonoscopy, you're increasing risk in a different way. Because colonoscopy, while it is very safe, there is a very small portion of patients who will have some kind of complication.
Okay.
And so if you multiply that by all of the 20-year-olds in the country, then you're putting some people at unnecessary risk. And so
that makes sense. Can I just stop and commend you both for doing what nobody does anymore? It's just such a relief to hear somebody who has gone through the training and does this for a living say, we don't know. And there's just something so comforting to not being hit over the head with, just some theories. And I just want to thank you for your honesty.
I think it's a lot of how we're trained as doctors.
I hope
we can't really pin any one thing on a certain cause because the biology in the world doesn't work that simplistically. I think people want to hear an easy answer. But the truth is that even just basic, medical conditions that you think about, the ramifications are endless possibilities. We can't just say simplistically that, this is the cause of this, and if you do this, then this will never happen. It's just too simple.
It's too simple, and we're so used to being fed that on social media. It's such a breath of fresh air. So thank you.
I mean, I do think that more research definitely needs to be done because even though we don't know exactly what it is, we do have some ideas that definitely need to be explored, and it's a opportunity for us to do better.
Well, one theory that I've heard thrown around, and being originally from Kansas City, I don't like it, is barbecued meats. So can you guys please confirm or deny that that's a problem? Because some of us come from barbecue meat land.
Yes. Red meat is not healthy for the colon.
And but specifically on a char, a charred meat.
Charring creates oxygen radicals. They are very harmful for the body. And of course, everything we talk about with diet is with moderation.
Right.
So it's not like you're banned from ever eating red meat or barbecue. But red meat itself is pretty pro-inflammatory. It's not particularly healthy for the colon in large quantities over many, many years.
Okay. So just be aware. Enjoy moderately.
Yes.
Okay. So for those of us who are either new to this or maybe, we're getting nudged by our family and friends, go get this done. I don't really know what it is. Can you kind of walk us through the screening options? Because I've also done the test where it's like, okay, you go play scientist in your bathroom and send this to us. But apparently got some really good information out of it. So can you just kind of walk us through all the options?
Yeah, I mean, I do think that one of the great things about in the past couple of decades is we have more options now.
Right.
So the gold standard is still colonoscopy. And the reason being why it has the highest yield or accuracy of being able to detect cancer. But I always tell my patients, really the biggest benefit with colonoscopy is being able to detect and remove precancerous growths called polyps.
Yes.
They look like little warts. If I find them, I can actually remove them when they're small and that they're at the precancer stage so that they don't have any chance of becoming left alone and becoming cancer in the future.
Okay.
So it's really, I would say the biggest benefit with colonoscopy is the ability to prevent potential colon cancer by being able to remove these precancerous growths. Now, the word precancerous is scary, and we do take it seriously, but precancerous polyps in colon are extremely common.
Right.
And, being able to find these and remove them, drastically does reduce the risk of colon cancer in the future.
Okay, that makes sense, because that's instead of just going like, well, you're all clear or you're not, come back and we'll remove it, it's done.
Correct.
Okay.
And, once you start forming polyps, you're more likely to form polyps in the future at different places.
Oh.
So that's why, if I, based on the number, the size, and the pathology result, the biopsy results of the polyps, I usually tell patients to come back usually earlier than 10 years.
Okay.
So if we don't find any polyps, and you don't have any family history, I might say come back in 10 years. But if I find, multiple polyps, it might be like 3, 5, or 7 years.
Okay.
That goes for family members too. If you have family members who have polyps, then your risk of having polyps is higher as well. So that also affects, the interval that we may recommend.
Okay.
Get
So this is encoded in your DNA in a lot of ways.
It is
It
in
is.
some sense. But, when we ask patients, like, do you have a family history of polyps? Most people don't know because it's not like...
No idea.
It's not
something that
something
came
you
up at dinner.
typically talk about at
Yeah.
Thanksgiving dinner. But you should take that opportunity
Yeah.
to talk during Thanksgiving
Right.
dinner about, about your
Yeah.
polyps.
You like doing this? Should we keep doing this for a long time? Tell me about your history.
I always tell patients, especially if I remove a lot of polyps in the colonoscopy, I say, listen, ultimately this is up to you, but I highly encourage you to talk to especially the first degree family member.
Okay.
So your siblings, parents, children. Hey, I had a colonoscopy. I had a lot of polyps removed.
Okay.
My doctor said you guys should really get a colonoscopy and get that checked out.
I certainly would never ask you to break any HIPAA laws, but I am kind of curious about something. What's the most polyps you've ever seen in a colonoscopy?
I
Just out of
think
curiosity.
for me, I think somewhere like 19 or 20.
So they're all also genetic conditions. They're
Yeah.
not
Wow.
they're not common, but there are
not common.
genetic conditions that create a syndrome called polyposis, where people there's a mutation that makes the polyps form much more easily. And so patients who have a particular genetic condition called FAP, it's familial adenomatous polyposis, these patients form a carpeting of polyps all across the colon to the extent that they're guaranteed to have colorectal cancer in their lifetime and usually by a certain age.
Oh, that's so scary.
So those people are an anomaly.
Yeah, for sure.
But a lot of people do have polyps. It's very common. And like Dr. Kim said, not all the polyps become cancer.
Right.
But you want to tackle them before they become the
Absolutely.
cancer.
Well, now I feel like an underachiever. I only have one. So if this does happen,
Sorry, I know you asked me about other options. I
Yes,
just want to go
yes,
into that
please.
because I don't want to just say colonoscopy is the only option.
we know that's the gold standard.
That's a gold standard, but there's other options as well. So you can also get this. I think you mentioned the kit.
The at-home, yeah.
Correct. So there's mainly 2 different stool testing that you can do.
Right.
One is called and kind of popularized by like Saturday Night Live, made a skit about it. Cologuard. I think was it Woody Harrelson? I think was on that
God,
skit,
I see
and
that.
it's really funny. But basically, yeah, it's a kit that they send you to home, and you do have to, they'll give you a little hat that goes over your toilet. You have a bowel movement. You put a little sample in it, ship it out, and basically what it detects is combination of microscopic level of blood as well as like kind of cancer DNA.
Wow.
And
that
so
is incredible.
So if it's positive, meaning there is either blood or cancer DNA, then the next step is colonoscopy.
Right.
If it's negative, you're good for 3 years. The other testing is something called fecal immunochemical testing, or FIT or FIT. It detects every microscopic level of blood. And it's the same thing. You collect a sample, you bring it in, and it's either going to be positive or negative. If it's positive, again, the next step is colonoscopy. If it's negative, then you have to get that one. You have to get every year.
Okay, so it's a first step if you're just trying to put things in front of getting a colonoscopy.
Especially, exactly. And I have to clarify that
Yes.
These screenings are for people considered average risk.
Right.
So what I mean by that, people who don't have any family history of cancer or even like a lot of polyps, right? If your family has a lot of polyps, you really
Just
should
go, yeah.
get colonoscopy. Or who's never had a polyp before. So
Okay.
for patients, let's say you did share with us you had one polyp. So
did.
I'm just going to take you as an example.
do.
In 7 to 10 years, you should get a colonoscopy.
Right.
You really shouldn't go back to Cologuard. because you've had a polyp before, you are considered higher risk.
I see.
And the reason being is there's a lot of false positive and false negative results with the test.
Okay.
I always tell patients, screening is better than no screening. For people who are considered, who have polyp before, you need a colonoscopy.
Okay, that makes more sense. So say somebody does get a colorectal cancer diagnosis. What does the treatment look like? And I imagine it looks different for somebody who this is like square one, or this is like, whoa, we really wish you would have come in a couple years ago.
I know that's a really great question. And it really depends on each person's individual cancer features and how advanced it is. And you may interface first with an oncologist, a cancer doctor, or a surgeon, or a GI. It just sort of depends on who you ended up seeing first. But typically for colon cancer, the majority of time, the first step is going to be a surgery.
Okay.
And so those are for cancers that have not spread to other organs in the body. Once we have verified that with some workup, some imaging. So typically what would happen is, you get the colonoscopy, you get the diagnosis, you get a bunch of tests done just to evaluate to see how advanced the tumor is. So CT scans, some lab tests. And then if that all comes back clean, then surgery is usually the next step.
So you just remove that section. Okay.
Yeah. So a lot of patients ask me actually saying, oh, you're not going to just take out the tumor, you're actually taking a portion of my colon out. And the answer is yes. We can't just carve out the tumor itself. We have to remove a segment of the colon that contains the tumor.
Okay.
There are these little balls of tissue called lymph nodes that are next to the colon. We have to remove all of that together to get our best chance to get an idea of how advanced the tumor is. So for colon cancer, that is usually the first step.
How does that change does it change someone's day-to-day to not have that piece of their colon or those lymph nodes?
It's a really good question. Lymph nodes, you're not going to notice them. They just exist in the body. There's a lot of them. And then for the colon itself, it really depends on where in the body the tumor is located. If it's on the right side or the left side. It just depends on the anatomy of the colon itself. The majority of the time when we remove just a segment of the colon, there's no functional outcomes differences.
Oh, wow.
Patients are able to have maybe they'll have like one more bowel movement than usual in the day. But it just really depends on sort of where the tumor is located.
Okay.
Yeah.
So it shouldn't be, it's, and again, I'm speaking I'm in the dark. This isn't like, like suddenly I'm using a colostomy bag, or that's not what we're talking about.
No, so not for patients who come in in this routine basis where they're relatively healthy, their cancer is not terribly advanced, and they've had a bowel prep and everything. They go in for the surgery. They don't come out with a bag, and then they live a pretty normal life. This is specifically talking about colon cancer.
Yes.
Rectal cancer is a bit of a different beast. And so rectal cancer, we've actually had a huge evolution in treatment over the last 10, 15, 20 years. It used to be that patients would get radiation, and then they would get surgery, and then they would get chemotherapy.
Oh, wow, yeah.
But we've changed up the order of how we do things to get patients the best benefit of completing all three forms of treatment.
Okay.
Some rectal cancers, the early ones, only need a surgery. Some we can get away with not doing any surgery at all. So we can do just radiation and chemotherapy, and the cancer goes away. And then there's some very specialized rectal and colon cancers that if you actually give them immunotherapy, a different kind of injection, they don't even need radiation. So there's a lot of different treatments. And one of the benefits of being treated at UCI is that we have a rectal cancer tumor board.
Oh, my goodness.
I participate in this tumor board every single week. We have a big group of oncologists, radiation doctors, radiologists, pathologists. We all get together and we discuss every single rectal cancer case that hits our door because the options are so varied and so patient specific. Just a couple centimeters difference in where the tumor is located.
Totally different treatment.
May change our treatment options.
Wow.
So we discuss every single case. We get a consensus. We take this consensus to the patients and present them with their options. And at UCI, we can communicate with each other very, very quickly and very easily. When you're at an academic center, we have very close communication, very easy communication, where we can, immediately just message our our partners, our oncologists,
right.
and formulate quick changes in plans. And so
That is so cool.
So the treatment for rectal cancer is very, very different than colon cancer. But that just means that we have, a lot of people that weigh in and give us great information.
Well, and I don't want to get too far away from this because we're talking about treatment, and I want to talk about the robots. Can we talk about robots?
Absolutely.
Sure, yes.
So tell me about the robots.
So unlike what a lot of patients imagine, which is a robot doing the surgery,
yes.
The robot
I've seen them fold napkins. I've seen all kinds of things.
The robot is a set of 4 arms that I control as the surgeon. So there's a console. So I sit at the console. I'm not even necessarily touching the patient. Now, I do still touch the patient. There's still involvement before and at the end of the procedure. And there's usually an assistant at the patient's bedside who's helping me to manage the instruments for the robot. But I control all of the arms, and I get these a really great visualization of the inside of the abdomen because the resolution of the camera is so good that I can see, I can see lymph nodes, I can see the nerves that are around the pelvis. I can really get into deep portions of the pelvis that I would not be able to easily reach with my hands. And I make just these small little incisions, and I'm able to do the surgery through just little incisions instead of making a big one.
When you first started doing surgeries, were you already working with this kind of stuff, or was this introduced later and you're like, everybody hold on?
When I started my training, it became progressively more of a thing as I progressed in my training. The uptake of the robot has been just like really,
I bet just
astronomical in the past, 10 to 15 years. So the adoption has become very high.
Okay.
But for rectal cancer specifically, I pretty much always use the robot because it really gives me great maneuverability in the pelvis, which is a very tight location.
Yeah,
it's hard to get around
angles.
corners. Yes, it's hard to get around corners. So the robot gives me just so much more ability to maneuver in that tight space.
Incredible.
Than I can with my hands or with my physical eyes.
Yeah, right.
or the laparoscopic instruments, which laparoscopy is essentially like it's the version that we had before robot, where we still use it very frequently, but the instruments are all straight sticks. It's like operating with chopsticks.
Okay.
So operating with chopsticks, my hands are on those instruments. It can be fatiguing on my body to do that kind of surgery, but it allows us to stick with the same small incisions.
Okay.
So the size of incisions is probably about the same between laparoscopy and the robot, but the maneuverability and the visualization is much better with the robot.
So I would imagine, like this is just the next step in the future of...
Yes, and laparoscopy is never going away because it's such a cost-effective and honestly useful means of doing surgery.
Standard.
And surgeries are quicker with laparoscopy, interestingly.
Oh, really?
I think part of it is the robot makes us focus a little bit too much on some of the details. But it's, both of them are great tools for what we call minimally invasive surgery.
God, that is so cool.
So all of us as a group of colorectal surgeons at UCI, we all use both techniques for different purposes, and it does improve patients' satisfaction, I think, because their recovery is much faster.
Right.
There's less handling of intestines, and so instead of our big hands like touching all the intestines, it's just these little instruments. It's much more delicate. Patients just recover much faster, and they're at a lot less risk for certain complications.
And it's so funny. You go back and you watch these old medical shows, or something that takes place in the 20s. It's like this kind of like spooky hospital, and you're just like, I'm just so glad I live now. This is really, it's like really exciting stuff.
It is very exciting.
And neither of you, I imagine, are particularly squeamish.
No, not terribly.
Well, I thank goodness that we have people like you taking care of us. But when it comes to empowering ourselves, what would you say are like just a couple tips, lifestyle-wise, maybe diet, whatever, that we can do to kind of decrease? You're both lovely, but decrease our chance of ever having to come see you.
No, of course. I think, like we mentioned, diet does play a huge role. as Dr. Zhu talked about previously, eating a lot of red meat or processed food, eating a very low fiber diet, which incidentally, vast majority of Americans don't get the amount of fiber recommended.
For
so
sure.
Once you start tracking it, you realize how, I've actually been nowhere near. So, eating a high fiber diet, all of those can be very helpful. I think, there's definitely some research saying leading an active lifestyle can be helpful. Tobacco use and alcohol use does increase. There has been some evidence that does show increased risk of colon cancer. So, again, trying to avoid those, or at the very least, like moderation if possible. I think those come to mind.
Yeah, I think the amount of time that I talk to my patients about fiber is can be pretty shocking for the average person. But
if it was a drinking game, you'd be wasted.
But really, I mean, fiber is, it is healthy for the gut.
Yeah.
It's anti-inflammatory, and it does decrease risk overall, not just of colorectal cancer, but of other GI conditions.
Because, fiber is so important. I've heard a lot of good things, and I've eaten it. I actually don't mind it. But what do you guys think of chia seeds? Is it the end all be all, or is it just okay when it comes to like cleaning you out in fiber?
It's a great amount. There's a lot of fiber in chia seeds.
That's why everyone's like
eat
chia
it like
seeds.
most mornings. So.
Okay, there you go.
Yeah, I mean, I think the thing that I tell my patients about fiber, is so everyone's gut's a little different. We have different genetics. We have different gut microbiome, like the bacteria that live in our intestine. That's symbiotic. So that leads to different. Everyone's different ability to ferment certain type of, sugars or carbohydrates and fibers and things like that. So I have patients who do very well with certain type of fiber-rich fruit like avocado, kiwi, but then some patients can't handle that very well, most likely due to certain type of food intolerances.
Yeah.
So they, like I can't eat a lot of kiwi, which is very rich in fiber, but certain type of the sugars, fermentable sugars, that you can't handle very well. So I'm a very big advocate of listen to your body.
Find your fiber.
Find your fiber. Find your fiber.
Find your fiber.
Exactly. Experiment. Keep track of what food that you can tolerate and you can eat in good quantities that doesn't cause you too much bloating or
that is a big one. And finally, I just have to ask, because I take them and I know lots of other people do. I know I'm not 4 years old, but how do we feel about gummies, fiber gummies, or should we actually be eating food?
Not a fan.
Okay. Lay it on me. I want to hear it.
The gummies have very little fiber in them, and I prefer the powder because it makes you drink more water.
Yes.
Because the water is the other component that's really important.
Right.
Yes.
Fiber does not work
They
without
activate
water.
each other, right?
Yeah.
Well, it's the fiber grabs onto the water and helps to just, hydrate you. So I think the gummies are much inferior to
I'm
the powder
so glad I
version.
asked. So I will throw away my Dumbo feather that isn't doing anything for me. And we will, the powder, that makes sense because if you have to drink the water, you can't get the powder down.
But what you were saying about just how can we empower our patients is, I think the first step is awareness.
Yes.
And so just knowing that there is that risk out there, and maybe your personal risk is not going to be terribly high, but to know what symptoms to look out for, to feel empowered to bring to your physician, I'm having some rectal bleeding. What's going on with that?
Where do we go from here?
And not necessarily taking no for an answer,
Right. Being your own best advocate.
Advocate for getting yourself screening if you feel like you are at some risk.
Okay.
And to not be shy about talking about these things.
Right.
No one wants to talk about their constipation or their rectal bleeding. These are two of the most common symptoms of colon cancer.
Okay.
Absolutely.
So to know to bring those concerns up.
I can't thank you both enough. Dr. Zhu, Dr. Kim, you are literally saving lives every day, and embarrassment be damned, you're keeping us alive. So thank you so much for giving your time. We're so honored to have you both, and thank you for keeping us healthy.
No, thank you
We're
for having
happy
us
to be
here.
here.
Yeah.
Thank you.
Thank you.
This is Live Well with UCI Health.